Interesting.
Yeah.
Dedicated her whole life to like Lori Joe, our head nurse.
Yes, she gone?
Yeah. And
The bike lane.
one word.
Yeah, the next road over, those are all done.
Not by choice.
Plus,
I
you
think
can't
she's gonna come back.
the first time I came, I didn't see the thing,
She
because there was a
rides
truck,
motorcycles.
and I was like, so I had to keep
I
going
think there's
through
an
it.
offense.
You know, so you have to turn.
Nationwide trip.
Because before I
But I
just
think
go
she
around
is
and
the
park my Starbucks, headed towards the freeway. And now you have to see if there's a spot. Hope you get around the block before someone else comes by.
Yeah, I mean, I was there.
Quite the dance.
Yeah,
For her manager, a woman named Sharon Sack.
how's it going?
Kind of, just a little.
So,
I was
it
still
was-
back when we were in Sand Point, as we used to have. So,
Yeah.
I think I'm the longest.
You have electric chair.
And good Dr. Kirk, that was retired, right?
Yeah, so I'm now the oldest one in the group.
There we go. That's a check.
I like that seniority.
Oh, I told you, I don't really have the seniority, it's just the name only.
They don't defer.
No one cares what I say. Especially at home.
Unfortunately, they still like you to show up and
What's
work,
that?
though, you know, there's something about that.
I didn't see anything.
I put
Work
money on-
ethic.
Yeah, I put money on the books for the company.
Yeah, it's the work ethic.
I didn't see a thing.
Show up and do what it is. I don't know, it'd be interesting to see
Probably stop.
20 years from now, how the world is structured, I guess is a good way to say it. I don't want to sound old, but
You see? Sometimes.
it'll be interesting to see.
This young man came all the way from Tel Aviv to hear you.
Oh my goodness.
How are you? Good to see you. Why are you here? You told me you were going to be here.
I'm checking for options to see where I am.
Great.
So candidates today.
Marvelous. When did you arrive?
Last night.
Oh
Actually,
my
I have my
goodness.
first meeting at 8 o'clock at the Youth Medical Center, so I won't be able to stay. So I just want to say,
Oh, you're not even going to stay for a few minutes, or you want to get over there in time?
no, I can stay for a few minutes.
Well, this probably isn't relevant to Israel. It doesn't matter the crazy system in this country. Oh, it's so good to see you.
Good thing. How is everything?
It's good. Good. You met our new fellows?
Yeah.
No?
Hi.
Great.
Hello.
You must be dating, right?
Hi, man.
I don't know. Everybody's talking about top.
Also from the family from
Where are you from?
Iraq. You have a car?
Of course, using the bus.
Uber.
Uber?
It's the best option.
Have you seen Matt since you came?
No, but I will see him on Thursday. I have a meeting with him. So.
Okay, great.
Hi. Yeah,
I heard a vicious rumor yesterday.
That he was in
Bill
town.
said something like that. Yeah, I think David's coming. Suzanne goes, yeah, tomorrow. Oh, was the last
He mentioned it last week.
Yeah, it was all everything was in the last meeting because I don't know where we could visit my father.
New York?
Yes.
So you've been in New York already? Or on the way back?
No, just a couple of days. We arrived on Saturday.
Did someone, is this all on your dime or someone sponsoring this?
No,
How's the work in Israel?
it's different.
Yeah.
different.
Yep. Would be a nice one to do. But it's okay. I'm going to get used to it.
Okay.
Get used to it again.
Well, I certainly hope this goes well, all these meetings.
And my daughter turned 16
I hope
this
so.
week, so.
Okay.
Yeah.
Okay.
So,
Good. All right, keep well.
I'm good.
How's it going?
This is working for us.
Immunology is.
Not sure yet.
Check.
He wants to come back here, and they use an American Tyson one is ridiculous. So he trained in Israel up to his fellowship here. But he joined the
College.
No.
No, I got to go to ATX. I rotated.
His Israeli credentials would have to go back and do a pediatric residency, like drop back 10 years of his training.
Last year.
License.
Last year.
Last year, I thought it was last year.
I don't know if there's
Next year,
anybody
college
around
year.
that. He's even willing to do it. His family's been 45, his kids.
He was writing a question.
That's right.
Yeah, exactly.
Seattle is.
In fact, I was just reading a thing yesterday.
Oh, there you
that
go. No,
looking
no,
at
Oh, maybe I'm
academic
quality
positions,
ATS for my team.
20% now.
Maybe in a biz here, I might have to work with.
So hopefully that, will push towards maybe a little realism. But it's, yeah, it's ridiculous, like, even though he could be a fellow here and he was for 4 years, he couldn't be hired for you because of
All I know is that I
control
drove
medicine boards here. Because like, he would have had to
years
go
ago,
residency,
trained with
you know.
Go all the way down there again.
You have to be able to be internal medicine. So we had somebody who was
That's the
family.
requirement that you have.
That is very true. See, this is my argument for why I should go west.
Yeah, yeah, exactly.
Get over that.
Somehow there was these people
Decided to go
I
into
see children that
getting easier and easier now.
I mean,
I don't know if they
yeah.
would if he doesn't have an academic appointment or, you know, in other words, if it's just a clinical professor, that's why in Hawaii the university blessing or something. But at any rate, he's on staff there, so I don't know
I
how
got
they
you.
necessarily assume that he, you know, the pediatrics is the same as internal medicine as far as what you need to, because he didn't do a residency there, but he did a residency.
That's early. We never
I
have
think they
ours.
explored that, but somehow there was some short.
And there's surely a lot of.
I don't know, maybe the difference was
Charge
Canada,
nurse.
Canada, that's right.
Yeah,
Exactly.
although I don't think they're aspiring this
Yeah.
specialty positions that should be working.
It's like our head IT guy was.
We were at
like
Thompson
for 3
last
months
year, right? We were in Nashville.
medical school.
There is a way to get the foreign license accepted in the US, but the next level is very frustrating.
My nurse is a sponsor physician.
Is that right?
We should have quite a number of people turn out. So when people are so slow getting here, we switch to and parking.
So he just passed it along.
Protest against
Yeah.
pediatrics.
Make
Yeah.
sure that the
They made a decision.
Go
doors
ahead.
are
Yeah.
automatically open till 7.
Interesting.
I remember in grad school, like, once a year, there's 25
Yeah. Fun. Yeah.
extra warnings, but people try to break in and freeze all your lab device.
The
You're
poor
like,
fellows, the two of them are out.
Number one, that would suck. Number two, you're like, they'd all be dead 24 hours if you sleep anyway. They don't know what food is. They don't know what a predator is. They've never been caught. So,
Where do you park?
What's that?
Where do you park?
I lucked out by the, where the food service thing
Oh,
starts
right.
at 10.
Yeah. Oh, God. I'm like, I think I.
We were just saying, get here 10 minutes earlier every
Well,
time.
I did leave a little earlier, but
No, I know.
I'm like,
Well, between the construction and the bike lane,
yeah, I know. That's kind
there's
of
probably 20 spots.
Right.
We should have.
right.
Yeah.
I'd never eat out here. I know we're going tonight.
No, I literally, I think I'm like a mile away. I kept driving, going. Yeah, I know. Maybe I
Quite
should Uber
sure
next
any
time.
place that you find is
I know.
going to be safer.
Yeah, well, that'll
And
do.
changing,
Yes.
don't park here.
I know,
I
and,
know.
Yeah, exactly. They bring it out right after you park.
Well, I emailed him
Like
over
over
this.
I did.
Wow.
Are you impressed?
What time's you leave?
Great.
That
That was worth it.
Yeah.
I think it should say.
I don't think so.
You have a cell phone.
Yeah. Hello, sir.
Hi, good morning.
How are you?
Good. How are you?
Good.
Not so far.
Actually, no wonder I know. Later on today, yeah. The coffee is
Afternoon.
Hello, good to see you.
Graduate from college this year, so
unnecessarily.
Good, how are you?
But it is what it is.
Oh, I started at 4, so I'll
That would, yeah. No, well, we sort of have some ways like anyone that is somehow, I'm not paragraphs, but it gives you like elements, that sort of thing. I've sort of that's right. Yeah, I think that's true. My last text.
Allergist for 0.
Oh, yeah. The thing is, we don't do a lot of violence.
So do you take a call like once every 2 weeks? So in the second year,
Yeah, I know that's
he does like kind of it's an immunology in clinical immunology, but he also does rheumatology. So he does both. So I don't know.
I think, yeah, I will figure that out.
Oh, if a patient, yeah. So I would. Hong-Yan is kind of the keeper of the schedule, so I would email Hong-Yan as well to specify to see him in immunology.
Dad coming?
That's all.
Yeah.
They're in town. You tell your our 2 little dogs scared Peyton.
I know, Peyton.
Peyton was running in.
Do you have it all under control? Now it's
I don't like the virus. It drains me bad.
Oh, that's what I.
If it's in my category, you're a strong person, you can do this. And my words
Marshmallow.
We're gonna give her the Hulk.
I know. Gosh.
1 minute here.
What's the word of the day? Coding.
Yep. It's our sort of godson.
Oh, good.
First for 40 years. Memories there, child.
Oh, fine.
So it was fun. It was down at Bell Harbor.
That's the one that that whole.
Stand her up. Like, I gotta Oh, no, wow. Wow.
Yeah, you know,
Yeah.
you could tell
Great.
people were like dragging. Yeah, right. Our ride.
Yeah.
So what I did is I may have told you, but I walked down.
You guys ready?
The elevator.
Let's go ahead.
Light rail, 7 minutes.
This is a topic in all the years that we've been doing these sessions we've never had, and probably for those in practice in allergy, probably one of the most important things you do every day. And something, to my knowledge, no one ever teaches you. So it's very nice that Teresa Thompson, who to my knowledge is the national expert in this topic, far and away, is in this region, and kindly came to talk to us today about allergy coding. The word of the day is coding, for those wanting to get CME credit. So Teresa, thanks very much for coming and even finding a parking spot and getting up early. So it's all yours.
Thank you. The drive over was not as stressful to me as the parking situation. It was like, oh my goodness, where am I and how do I get there? And please don't take it wrong as far as following my GPS. We have about an hour. I tried to put enough slides together for about 45 minutes so that we can have questions too, if you have some questions afterwards. If not, that's fine too. Obviously, nothing to disclose. And this slide is very small in its content, but a lot of this has to go back to you for what you do every day, and that's working in your charts. And one of the things that it talks about, if it's not recorded, it did not happen. One of the things I was talking to my son about last night, he's a dentist, and he was talking about seeing patients and what they came in for, and what the chief complaint was, and why the patient is being seen. That really drives all of your encounters, and one of the things that you have to remember as far as in your documentation is you as the providers, the physicians, you are responsible for taking the history of present illness. Your staff can put down, if you choose, why the patient's there, but your responsibility is to take that history of present illness, not your staff. The staff can put things in if they want to, but you are required to add to it, take away from, make it so that it's yours in that part of it. If it's illegible, for those of you that still have paper records, that, believe it or not, that's still out there, it's not happening if you can't read it. The thing I find more with electronic health records is the cloning. And cloning means cutting and pasting, and you're bringing forward information. And how do they find that? That's one of the big things on the Office of Inspector General's list of things to find is how do they find cloned records? Well, usually they find it when things don't match in your documentation. Something that is in the HPI that doesn't go with the review systems. The exam doesn't match what's in the HPI, those type of things. And that's what they talk about is cloning, pulling things forward, cutting and pasting, making those things, then it doesn't count. So if something doesn't match, then they throw out that whole component for your level of service, and so it's lost at that point in time. Code to the level of knowledge at the time of the encounter. So one of the things that we talk about is medical necessity, and what you document and what you put down for diagnoses and what you give the patient. So you may anticipate that the patient's going to have allergic rhinitis or they're going to have asthma, but maybe you're not sure at that point in time. Don't go and default to that diagnosis, because now you've given that patient that diagnosis. And just to be repetitive, you've probably heard it before, but our diagnoses are used by insurance companies to determine patients' insurability. Hospitals' diagnoses are not. So they can code a rule out MI, they can code all of those things, and that doesn't go anyplace. Our diagnoses go to health insurance companies to make a determination as to what that patient's going to get covered for. So, if you don't think that, you're not sure, there's nothing wrong with giving the patient signs and symptoms. One of your dear colleagues who's been gone for a while, Dr. Shapiro, used to argue with me that she wasn't a good physician if she used signs and symptoms for the patient. And my point to her was, yes, but you're not giving that patient that diagnosis. Anyway, I don't know if we ever agreed, but we had good discussion in regard to that. So code to the level of knowledge, at the time of that encounter as it goes along. Your documentation starts when you walk in, you see the patient, and this is what you're here for. The other thing I always caution you about, because I have people across the country sending me notes saying, why isn't the payer paying for this? And it's usually evaluation and management services and allergy testing or desensitization or something on the same calendar day. Is that chief complaint if it says patient's here for a procedure, you're going to lose that evaluation and management if they ever do a review. So be cautious on that as it goes along, because you won't get covered for that. So in talking about the allergy testing codes, and this is kind of just a really focused review for you in coding, is where it talks about testing and ordering of immunotherapy needs to be done based on orders from the physician. This has become very much an issue in 2017 versus 2015, 2014. That has to be documented. There has to be documentation in your chart note that says, this is my order, this is what I'm prescribing for this patient. Testing is either precutaneous, intradermal, one test per antigen is usually what we do. There are some people that do what's called sequential incremental testing, where you have one antigen and you test it multiple times. The RAS testing is usually covered, but you need to check, because some payers won't cover it unless there's a reason why you're not doing regular allergy testing. They want something as far as a reason why you're doing those. And then the last two, where it talks about interpretation report included in the code for the test. Again, to drive home the point that in 2017, it is required that you as the physician interpret and read that test. It is not you may have the greatest staff in the world and they can read the test, they know what the wheel and flares are and what's included in those. That's great, but it's your responsibility to indicate in your testing, however you document it, whether it's on a paper that's scanned into your records or whether it's part of your EHR, that you have read that test, you have interpreted that test. And that's not just for the positives, it's for everyone. Which ones are positives, which ones are negative, which ones are clinically significant, which ones are not clinically significant. That's important. UHC, Blue Cross, Aetna, go down the list of payers. If they're not seeing that and then put it all just in the body of your evaluation and management note, you are going to lose the evaluation and management. So make sure that your interpretation and report is included in that test. That's part of that test. It's a separate document as it goes along.
Can I ask you a question?
Sure.
Point number 3, I don't know, does that refer to what we in our specialty have often called wrinkle, or the kind of testing that...
It used to be called wrinkle, and it's now changed.
So we've never thought that was a proper way to practice allergy. Does it still get paid for when ENT people do that testing?
Yes, by most payers. I can tell you only one that I know of that doesn't, and is Cigna. There's so much gray today between how board-certified allergists and ENTs do that it's kind of a moot point anymore. I also see some board-certified allergists do this sequential incremental testing when they do vial testing. You know, everybody's unique in that. Not that they bill for it, but I do see them do that as it goes along.
So Teresa, back to the interpretation report. So you can't just say that they've got like positive tests to like RAS and decimates. You have to say it's significant, that it's pertinent to their history, and not in the assessment in that area. Or what do you say that again?
When I say interpretation report that's included in the test, you have to tell me, for example, they're allergic to trees and grass, okay? Maybe those are clinically significant, but maybe they were 1+ positive to cat. Maybe that's not clinically significant, okay? So you can have a grid that says this is the ones that are clinically significant, these are the ones that are not, the rest are negative. But you have to make something on that testing sheet that indicates that. We're getting more push, and there's a couple of reasons for it. It all has to do with cost. But the more that we have different different specialties dabbing into our specialty for allergy to bill more allergy tests, and we can go on and talk about those if you wish. But then the payers come back and start looking at us to make sure we're justifying why we're doing what we're doing. Okay, so that's part of that. All right, any more questions on that? All right, so these are your codes, and my world is codes, and your world is taking care of the patient. And these are the codes that you use. And so when we go through and we talk about these, you all should know these, that the 9505004 is for your precutaneous testing that you do. Your intradermals that most of you do is the 95024. They changed this code some time ago for venoms that includes the precutaneous and the intradermal. The 95018 is for your drugs and your biologics. And then the 95027 is, as I said to you, the sequential incremental. I don't do these very well. Go back. Okay. And then the 95028. How about that one? Does anybody do any delayed ID testing?
No.
Only time I've heard of it, and I was actually in the southern part of the U.S., was from mold. I don't know if that's unique to them or, whatever, but that's the only one that I've ever heard as far as delayed ID testing, because we do tests for TB, but there's a code for that and those type of things, but that was the only time that I've ever heard that.
Years ago, we used to do, and it always after medically valid, delayed reading on penicillin tests.
Yeah.
Warren Bierman used to do that, and people come back and theoretically it correlated with delayed cutaneous penicillin reactions. I never bought it as correct, but
Yeah, and some people are doing that with food still.
And they're doing it with foods?
But, yeah, it's not
standard.
accepted as, practice parameters will not advocate
Support
either
it.
of those things. Yeah.
Okay. All right. The patch testing, everybody, the biggest question I have on patch testing is, can I build evaluation and management codes with it? Because patch testing is so much different than your regular allergy testing, because you put the patches on, you see them back in 48 hours, and then maybe you read in 72, something like that, as far as what's billable with those. And at that 48-hour encounter, can I bill something for that? Because it's usually nurse-driven at that point in time, unless there's something that's happening. And most of the time I will tell you that there is really nothing that you can bill for that unless there's nursing care given. If there's nursing care given, then you might be able to support a nurse visit with that. Nurse visits also usually have copays, so you have to look at that for goodwill for your patient, whether you choose to do that or not. Is there something that's an addition? And then the last one, the 72 hours, yes, you can bill for that. And in my opinion, that encounter probably is by time, because it's counseling, coordination, care, whether you have a pertinent positive or negative patch test, because there's no reason for a history exam. It's, this is what the results are, this is what we need to do at this point in time. The inhalation...
Question on that. So when they're placed on day 0, so many tests are applied, and then they're read 72 hours later. So how are those charges divvied up between, how is that billed or paid by the insurer?
at 48 and 72 hours in our office.
But there's a reason the dermatologists dump this on us, because you don't get reimbursed as much as, unless you're doing a ton of
You get
large
you
panels.
get you get money for each patch, and so I think like most reimbursements is like, let's say $11 per patch. So if you do a true test, there's 36 patches, so you're billing let's say $360 or something, and so that is, you put that on day 0. Now if your nurse puts it on, you're still billing for those patches. But when they
If
come,
you put it on both times, I was just curious, how is that actually?
It's a per patch thing.
It's
So
per
so
patch.
it doesn't make any sense financially unless you do the whole panel, which is not the way we
or
do
if
skin
you're making
testing
your own,
usually.
then it's less expensive.
Yeah. But if you just think it's nickel, it's a loss leader if you just test nickel.
unless you make your own.
Because you have to usually use the whole patch test kit, don't you?
If you do the
You can
true
do a
test.
thin chamber, but even that, the time it takes to mess around with that, it's sort of depressing.
We'll come back to that. Maybe we'll come back with a better answer for you. How about the inhalation bronchial challenge? Anybody doing those?
Well, yeah.
Yeah.
You don't get reimbursed enough for those either.
Methacholine, Steve.
Yeah,
With the
methacholine.
methacholine, and then are you doing the scopes in addition to that?
I do, yeah.
Yeah.
I'd be curious about since it's been 20 years since you advised me on how to do that.
And
Because
you're still doing it.
well, I do it because I enjoy it, not because it makes any money.
Yeah, I know. But I have to say that you probably there's a few folks out there across the country that do that other than you, but that's, I mean, there's nothing that's bad about that. I think you get reimbursed for those things. There's some issues that are coming down the pike that just actually started in regard to the scopes, and we'll talk about those in a little bit as far as what the issues are. The ingestion challenge codes, those are probably the big ones for the last few years because they were new codes. And the ingestion challenge test, the 95076, when can you start for the first hour of the ingestion challenge? You can start, or the first 120 minutes, you can bill for it at minute 61. You have to go through that first 60 minutes, and then on minute 61, you can bill for the first hour. And then people have reactions.
Have they approached you about the phenomenon of updosing visits?
For foods?
When there's going to be presumably an FDA-approved product in a year or so from now, and they'll need anywhere from 20 to 40 weeks of every 2-week visits with observation. If it's just one dose, it's going to be very hard to break even on that either. Yeah.
But that's not a challenge.
No, I know, but maybe I'm jumping the gun. I'm
Yeah,
sorry.
we'll get to that. So that's not a challenge. There's a difference. And one of the things you have to realize, again, questions that come to me is that what yesterday was a question, I want to do a challenge and desensitization for aspirin. You either challenge or you desensitize, one of the two. You may start out and say, well, if you react, I'm going to desensitize you. Then you should bill it as a desensitization. If you're challenging that patient, that's it. You're trying to find out if they have an allergy or they have an allergic reaction to aspirin or peanut or whatever it is, then you're doing a challenge. Okay?
So just to clarify, if a patient reacts to the challenge in the first 120 minutes, is it just an E&M code, or?
If you have that patient that has met the 61 minute, then you can bill for the first hour. You can also bill an evaluation and management for the reaction. So you can do both. 2 notes. One for your challenge as far as your form goes, and then another one where you pull out a CPOE and you actually document a note for that encounter for that reaction that you're taking care of. You should have 2 different diagnosis codes. Okay?
Can you do, like, for penicillin, all the skin testing and then do an ingestion challenge? Say after that, because you want them to
That's
take
on
some-
this
Well, you
on
want to
that
repeat
side.
Pandora doesn't speak loud enough. so
Our
everybody
question
hears
is, can
that.
you charge for the precutaneous subcutaneous test and the challenge on the same day? Isn't that your
Yeah.
question? And the answer is yes, you can do both on the same day. You can do the skin for the precutaneous intradermal test and the challenge on the same day. There's some guidelines. So in one of the pharmaceutical companies out there that had little cards that they made up and they were handing out to people to do penicillin testing, and it said you gave them a dose, you did the skin testing. Was that you?
Yeah.
Bad, bad. And you gave them 1 dose, and you could bill for an oral challenge. That's wrong, right?
Our cards say that you can with the oral challenge at the 61 minute, along with, I think, 7
And
other
how many
codes.
doses of penicillin do you have to get?
2.
Minimum
At
of 2.
least 2.
Right.
Because
Yeah,
it's sequential,
altogether.
incremental. So hopefully you fixed your cards.
Yes, we have new cards this year. If I knew, I would have brought them.
You should have fixed it several years ago. But that's one of the big issues that a lot of people got in trouble for because they were doing the sequential sequential increment. They were doing the testing, the 95018, and then they were billing the 95076 because they gave them one dose of amoxicillin and had them sit in their office for 61 minutes and build the oral challenge. Won't work. Doesn't support it because the code says sequential incremental doses. Okay? So, however you want to give that, that's fine. But you got to have that sequential incremental doses.
5 milligrams and 5 minutes later.
Okay?
Can I ask you a stupid question?
That's why I'm here.
Good. Who actually sits and reviews all of this and watches over what we do?
In regard
It's like
to
cheating on your taxes. It's like cheating on your taxes.
Yeah,
You can get away with it,
IRS
but
checking us,
good luck.
or the White House?
well, you want the short answer is the payers are starting to. I had a group that said the payer wasn't paying them because the diagnosis codes lacked medical necessity. So that's a scrubbing thing when the claims go through. I had another group that contacted me that this particular person was being held on criminal charges for doing things inappropriately. I mean, that's on the really bad side of the world, you know. But so who's looking at it? Everybody.
Yeah.
Okay. And it's not just Medicare. It's Blue Cross, Blue Shield, Aetna, Cigna. Probably for us in our world, United Healthcare has been a really big guy as far as doing chart reviews and looking at all this stuff.
And a lot of times the reviewer is not a peer. They say they are, but they're a family doc that doesn't know what you're doing. And so it's really, you have to talk to them face to face or real time, and you're lucky to get them to change it.
One of the things to remember is when and we'll go again back to what you can do on reviews is you can ask for an allergist to review your client, somebody that's in your peer group. The other thing you guys are doing injection challenges. You're doing drugs, I guess, as far as you're doing a challenge, and as far as testing goes. You're doing sub-Q injections. Anybody doing those in this group? I don't know, but I get this question on a repetitive basis. How do I code for a sub-Q test? And there isn't an allergy code to do that. What you have to use is your regular injection code that you would use for giving a steroid shot or something like that, which is 96372. So
Would that be like for cane testing? Is that what you're thinking of?
Yeah.
Where you doing
Where you might do some, and then you might do some sub-Q injections to prove that they're definitely not allergic.
And so you're going to use that code, and you're going to
Or
have
a
a
flu
unit.
shot, like
So you should do
96372.
96372.
Use it like you did a vaccine at a partial dose to make sure they're okay. And they
Well, if you're doing like a flu vaccine for a partial dose, I'd still use your flu codes, your immunization codes, the 90471 and 90472.
So you don't get extra reimbursement for having to. You do 1/10 of a dose because they said some weird thing happened. And,
No, but you get the bill for 2 shots.
okay.
You get the bill for 2 shots.
Misread the Academy police. It said just give them full dose and don't listen to the history.
Well, for egg allergy, yeah, but sometimes they're just crazy or whatever, or they had an anxiety reaction.
All right, so
Maybe
those
there's
are
a
your
super code for
those
crazy.
are your testing codes. Let's talk about something that has impacted you that you probably don't hear a lot about. And these are called medical unlikely edits. These are published by Medicare.
You sound good.
And they were part of the Correct Coding Initiative. Why do I bring these up? Because in July of 2016, they came to haunt us in allergy significantly. And there's this slide here that talks about how you interpret the edits. So, and I don't do very well in getting this mouse to work over here. So, the first one on the left there where it says 95004 and it has an MUE value of 80. What does that mean? Well, the problem with this is, well, this was published by Medicare, so Medicare, Medicaid, they're going to go by this. But what happened was Blue Cross came along and said, we're going to follow this guy. Cigna, Aetna. There's a few that didn't, but those are the ones that did. So when you do the 95004, you test the patient. Let's say you do 100 precutaneous tests on the patient. You're only going to get paid 0 because you went over the 80. Okay? So you have an edit there that says anything that's higher than that, I'm not going to pay you for. If you go down, the 95012 is for your NIOX. You can do 2 on a calendar day. That's it. And so the MUE adjudicator says whether it's a per day or per line item. Okay? The 95024, you can do 40 of those for your intradermals. The 95044, this one should have helped you because they, instead of using the true test, which is now about 40, they went to the American Standard Patch Testing, which is 80. Okay? So you can do 80 patch tests in a day if you choose. And that should go
Isn't that the Canadian one? I mean, because I thought the 2 main ones were the true test, and then there's a Canadian one that's a panel too.
I don't know, Dr. Tillis, for sure, but I know that there's one that they call the American that says it's 80.
And when you said if you do more than 80, you don't get paid anything, does that mean they void the first 82 or just everything above 80?
No, what happens with MUEs is if you go past that MUE, they pay you 0. And so then you have to resubmit with 80 to get paid for the first 80.
So you do 79, you get paid for 79, you do 81, you get paid for 0.
If you do 81, you get paid for 0.
But then you have to resubmit it. Then you have to resubmit it at 80.
You're also telling us that people who do 80 prick skin tests?
I hope not.
Yeah.
California.
I can tell you people that do hundreds.
Yeah, I mean, it's amazing what happens.
At least selling this
The practice parameters.
Practice parameters
Said
gave
70.
suggestions.
Yeah, but
We didn't
Look at the bottom one though. See the 95076 and the 95079? The 95076 obviously is for the first hour, so it's only 1. That's applicable. But the 95079 is only for 2. Okay? So if you have someone you're going to do 2 hours. So that's a total of it's for each additional hour. So if you have somebody that goes past 4 hours, then you probably aren't going to get paid. Now, if you do a challenge on 2 days, then you would get paid for the 2 days. Okay? Because this is data service. So these are important for you as far as what has happened with this.
So, Teresa, for the penicillin testing one, or the antibiotic one,
Yes?
this says 19,
Yes?
right? 95018. Is that in a year or is that in
On
a
a
day?
day.
In a day. Okay.
On a day. Data service.
Okay.
There's a lot of discussion at this point in time, and I don't have a definitive answer. I would really like to. Maybe you do, Dr. Phyllis, as far as whether the controls are included or not. Historically, we've always billed for controls.
I thought we do, yeah, because it's
Historically.
you can screw that up. You have to have expertise to do it right.
Yes, but there is, in this great publication, and someone reading the fine print has said, oh no, those are included. So I always like to point out what the limit is, and then it's up to you to make the business decision what you're going to do, because that's kind of one of those that's up for discussion that we really haven't had an answer. So don't be surprised. So 19 is that. And the 95017, 27 to me is the 5 Bs, 5 times 2 controls. But that would be 27 as opposed to. All right, pulmonary services. These are things that you do for your PFTs. I will tell you just a heads up that in 2018, you will have a new code for an exercise challenge versus a 6-minute walk. They're taking the 94620 and deleting it and making 2 codes, one for a 6-minute walk and one for an exercise challenge. So
Presumably, the exercise challenge will be justified at a higher billing.
I haven't seen an RVU yet. We'll see. You know, sometimes that works, sometimes it doesn't as it goes along. The one of the best things about being not clear over here on the left side of the country is that your 94664 for your MDI instruction should still be getting reimbursed. You guys do it all day long. You should bill for it. If the payer says it's included, whatever, write it off, but you do it, you should get paid for it as it goes along. As long as you document it as some kind of note that you have. The 94060 is your pre and post bronchodilator, and with a bronchodilator. That is pretty standard. I have seen a few payers kicking back if you do it too frequently. They'll pay for either your flow loop or your spirometry on like once every 3 months or so. But the 94060, they seem to want not repetitively unless there's a reason for why you're doing it. The patient has an exacerbation, etc. Yes, sir?
With the inhalation treatment to use inhalers, does that have to be the physician or can that be the nurse?
It can be the nurse as long as there's something documented. That's how it works. Okay? The prolonged bronchospasm evaluation, the 94070, usually goes along with your methylcholine challenge as a separate because you're doing multiple spirometries at the same time. The 94640 non-pressurized inhalation treatment, that's your nebulizer treatments you may do in the office, those type of things. There is also, it doesn't matter if you do 1 or 2, you only can bill it once. The 94644 and 645 usually are hospital things as far as continuous treatment. Oximetry is a vital sign, the 94760. We're supposed, unless the patient just comes by and you do a pulse ox on them, that's it, because it will get included. You can for the multiple, the 94761. If you're doing multiple spirometries, you can get reimbursed for that. The pulmonary stress test, as I said, in 2018, that's going to be gone, and you're going to have a code for the 6-minute walk and a code for an exercise challenge, which I think is a good thing. Your flow loop and your spirometry usually come off at the same time on the same report. Whichever one you choose to bill for, you need to comment on. The pulmonary function tests, we haven't had as much issue as far as getting denials from them as far as your interpretations of those. But, you know, the rule goes that if you do a spirometry, comment on the spirometry if you bill for it. If you're going to bill for the flow loop, then comment on the flow loop. Comment on both if you're concerned.
Are you finding that that's not getting billed multiple times per year? Because a lot of the patients say their insurance only covers 1 spirogram, and then after that.
I've heard that. But I think that the most common things I've read in what's called medical policies for payers, that they will pay the spirometries the once every 3 months, the baselines. The 94060 usually is once a year, or if they have an exacerbation, which comes back to you to say, when they have an exacerbation, don't just code asthma. Code the URI first. Why am I doing this? Well, yes, their asthma is worse, but what's causing it? It's the URI that's causing their asthma to be worse. So code that first, code asthma secondary. You may have an asthma with acute exacerbation. Use that code too, as far as what it is. So you've got to make your diagnosis coding order very specific in those things. And then the vital capacity, I put this one in here because people want to bill for it, and if you do that in a spirometry or anything else that day, they only pay the vital capacity because that's the lowest valued code for that. And then NIOX, I don't know, in Washington, are you doing well with NIOX? Are you using NIOX?
Better than 5 years ago.
Yeah. We're using it a fair amount. The U's not using it at all.
Oh,
What'd you get?
It
one?
arrived yesterday, the
Oh,
machine.
okay.
Oh, things
Oh,
changed
right,
yesterday.
yesterday.
Great. Do you know if we're getting paid?
Yeah, I think you are getting paid. You actually can do it and a spirometry. You know, I see both once in a while go through on a claim.
Yeah,
Well,
they tell you different things. So
yeah, you
Yeah,
should do
Yeah.
both.
and I see both of them get paid. Now,
and I think Regents is still tough, isn't it?
the other
They
thing
were
that I
slow
do
for a long
see
time.
is that some people feel very strongly about the NIOX, and so if the payer doesn't and these are business decisions, not my recommendations, but I do see people that if they feel very strongly about the NIACs, they have patients sign waivers that say if it's not covered, the patient's responsible for it. So that's an option that you can do. So it depends on your policy. Okay, the scopes, the nasal endoscopy, the laryngoscopy, the nasopharyngoscopy. You bill the one that goes the furthest. So if you're going to look at the larynx, you're going to bill the laryngoscopy. You're going to do the nasal cavity, you're going to do that. Obviously, the pharynx in 19511. Separate procedure notes. You should have seen in some of your bullet points, this started back in Pennsylvania probably about 3 months ago, maybe more, that the Blue Cross back there has decided that they are anytime you do a procedure, and these are the ones that are going to be impacted, that you do one of these procedures, they're going to pay you 50% of your evaluation and management code. Regents just adopted that same policy.
So if you bill this in addition to the E&M code, you'll get 1.5 E&M.
You'll get half of an E&M. So if you're charged, let's say they allow $100 for an E&M, and then they pay you full value for the 31231, they're going to give you $50 for the E&M and pay you this.
That sounds weird.
So, all right, say that again.
So if you're doing the E&M separately, or like say you do a history, you ask about their family, even though you saw them last week, and the review systems and everything, you bill a level 3 because you've seen them before, and then you do a 10-minute laryngoscopy. You bill both. Which of the sum of the two minus what is what you actually get paid?
They have determined in their own wisdom that that when you do there's two that they're doing it for. They're doing it for preventative services. For us in preventative services, and I don't know how many of you do this, bill for smoking cessation. Anybody ever bill for smoking cessation?
We document it, but we don't bill for it.
Okay. Well, that's a preventative code. If you do it with a preventative code, they'll pay you 50% for the E&M.
So you're better off not to.
You're right. You're better off.
Why would you want to do smoking? Just tell them to keep smoking.
Yeah.
Makes for better business, right?
Get down the road.
And they only pay you 25%.
Exactly.
But the scope procedures, they have started out and the Blues are looking at this as saying, even though it's separate and identifiable for the E&M, they only want to pay you 50% for anything that has a 0 global day. These have 0 global days. Most of our allergy testing codes have that. They don't, that's not applicable to us. But these it is. So don't be surprised. Watch your contracts for that, and it will be in the billing manuals as far as somebody will get something out that says, oh, we've changed our policy as of August the 1st, that this is how we're going to do it. So that brings us to this, the 25. And this is, Dr. Tullis is right. It says it's identifiably separate and identifiable evaluation on the same day. Okay? This is why I come to you and keep saying to you, make sure that HPI is right. Make sure that there's something in the body of the note that says, I've decided based on all the things today that I need to allergy test this patient, because it seems to me that as we go along, we have more and more problems getting evaluation and management codes paid with allergy tests on the same calendar day. It really helps if you have different, and your coders are putting diagnosis codes in that are different for each line item thing. Then you have your E&M that is for nasal congestion, your allergy testing for allergic rhinitis. But this modifier is the one that we use repetitively for that. But we have to make sure that it's being used appropriately. This is the global day period that it talks about, the E&Ms, that when you do the challenge, can you bill for an E&M? How many, let me rephrase the question. How many of you bill an E&M when you do a challenge?
What kind of challenge?
Oral challenge.
No, we don't.
Unless there's a reaction, you give them
Unless
epinephrine
there's
or
a reaction, okay? How many of you What's included in that oral challenge? Taking the history, doing the exam, enabling you to do the oral challenge that day, correct? You see them afterwards. What do you do afterwards for that patient? You tell them the results of the challenge, right? What about the counseling, coordination, and care that goes on after that? Does that get bundled into this challenge? And how long does it take for that encounter? Those are things you think, because what's included in the testing is the history and exam to do the test, the testing itself, the interpretation of the test, and giving the patient the results of the test. How to live their daily life is not included in that. So that's something that is on and beyond as it goes through. But you have to make sure that you meet that definition. All right, so third-party payers requirements for usage 25, 50% reduction in an E&M when it's performed on the same day as a procedure with a 0 to 10-day global period. That's the newest thing that's come out from the Blue Crosses across the country. Whether Blue Cross here versus region, Premier will do it, I don't know, but there are some that have done it. The other thing that is pending is United Healthcare was going to implement no coverage for consultation codes starting August the 1st. They have delayed that until January, and so they're going to go back and revisit that at that point in time. Okay, immunotherapy. How many of you write a prescription for immunotherapy when you do it? Okay, when you see the patient when the patient needs a refill, do you write another prescription? Yeah.
Change the prescription.
Or change the prescription. Or the nurse gives you something that says the patient needs a refill of their vials, okay? That has to be documented again, okay? That's part of this policy. You'd be surprised how many allergists don't do that as it goes along. Once they get into the process, they just go on and on and on as it goes along. And the payers are coming back and saying, if there's not documentation that the physician wrote the prescription, they refill the prescription, this is what's in the prescription, we're not going to cover the immunotherapy. Okay? So they want that documented. They also want documented the number of anticipated doses. Okay? That we anticipate to give the patient. Now, that doesn't necessarily have to be done by you, but somebody has to anticipate how many doses we're going to give that patient. Whether it's a new treatment set or whether it's a refill. How many doses do we anticipate? The reason for that is the CPT code says bill for the number of anticipated doses. So you cannot have a set formula that says everybody's going to get 120 doses or everybody's going to get 80 doses. How many does Teresa going to get? How many does Susie going to get? No, that's the number that we want. How many do we anticipate? And what they do is they go back through and look at your shot record and see if it matches more or less with what you anticipate. Now, the patient may need more doses. They may need less doses, but this is what we anticipate to give them. Okay? That's a big one. The off-the-board treatment. The other one I've had a lot of questions recently on is people that have decided to outsource their immunotherapy lab, and they are getting one of the manufacturers of antigen to make vial sets. How can you bill for that? You can't bill your 95165 code because you're not doing the supervision preparation of those. So the only thing you can bill for that is codes that are not recognized by Medicare for that. So it's going to be cash for the patient or an unlisted code. And then the last one, there's limits on the number of doses allowed per the carrier guidelines. And somebody said, oh, I want to just bill everybody the same. The most common comment I get is, I bill everybody by Medicare guidelines. Well, you're losing revenue if you're billing by Medicare guidelines. Because if you're billing by Medicare guidelines, you're billing by volume. And even though many of the payers have used Medicare MUEs, the medical and likely evidence, they're not adopting the guideline that says we're billing by volume. So there's not one standard as we can go through. So Cigna has limits. United, Aetna, those all have limits that are someplace between 80 and 120 units per year. Depends on the payer, depends on the coverage. Some of them are rolling years versus calendar year as far as when it does. CMS actually has a limit of 30 per day. So if it's a Blue Cross Premier, Medicaid in our state, they go by CMS guidelines, then you can bill 30 units per day, okay? But if it's at the United Cigna, then you're going to have to bill per their guidelines. What if the patient needs more than what they allow? Can you balance bill the patient? No, not unless that payer tells you you can balance bill them, but routinely no.
We've sort of flirted with rush desensitization, and that's an hourly fee instead of the number of shots. Is that totally different than this, what you're discussing here?
Well, not necessarily, well, to a certain extent, but not all. The problem with rush desensitization, which you would bill with this 95180 down here at the bottom, is because it's per hour, is when they went to ICD-10, the payers went to ICD-10, a lot of them will not pay rush for regular allergens. They will pay it for the drugs, but they won't cover it for foods, and they won't cover it for regular allergens. So check the policy before you do it and see if they will cover it. Because when you do rush, the difference in the doses is you're billing, rush usually you use less doses than if the patient's coming in over a significant longer period of time. So your number of anticipated doses are going to be less. And you still bill your doses in addition to your hourly charge for your rush. You don't bill for the injections because that's included in that rapid desensitization code. Okay?
Could you go back a slide?
Sure.
Well, CMS 30 units per day. You're still talking here about immunotherapy?
Yes.
I don't understand that. Could you explain that?
30 units means you can bill for 30 doses. In Medicare's world, that would be 30 mLs because Medicare bills by volume. So you bill the 95165 and you could bill for 30.
So that's
mLs.
mixing for the year's worth in one day, 30.
You could.
Well, because
yeah,
how are you going to give 30 per day otherwise?
No,
For Medicare,
it's
for
the
Medicare,
anticipated
you're
doses.
correct. It probably
Yeah,
would
so
be.
the per day is just misleading because it makes it look like.
So the
it's
thing
like
is like, let's
you're
say,
mixing them and billing at that moment, but it's not for that day.
Right, it's
Yeah.
for that. It's for the year, for a day, on a day.
so you have a patient who has let's say two vials and they're a new patient, and you anticipate that they're going to do 45 doses for the year for vial 1 and 45 doses over the year for vial 2 because they're going to do all this build-up time and then they're going to come in every 2 weeks. So technically they have 90 doses, but for some of the insurance companies you can only bill 30 at a time. So you can bill 30 for 3 subsequent days, correct? Because you can only bill up to 30 in a day, so you have to bill, but you know you're going to have 90 doses over the year, so then you're going to bill 30
So
each
you
day.
make the antigen in one day, but you spread your charges
Correct.
over 3 days?
Correct.
That's what we're-
legit?
yes,
You
that's what we've been
legitimately do
doing.
that?
Yeah.
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 Because otherwise, well, what happened was we were only billing for 30.
You say that publicly?
Well,
How's that legitimate? You're
have
you're
no
billing
idea.
for
I
something, but
didn't
you're not
know.
doing anything on those days. How is that legitimate?
Well,
No, I'm asking her, not you.
the only deal, if you again, back to Dr. Alban's, who's looking at us, is as long as you can justify in post-payment review those doses have been given. If you really want to be exact about it, you have to go to the people that are billing every time that the patient comes in for a shot, they're billing a dose, because now we're exactly correct. The other option is to bill as the patient in the person area where they're building up, and they're going from vial A, B, C, and up, is that you bill every time a new vial is opened, and then you bill for the doses in that vial. So,
well, that gets really complicated because then
it does get really complicated. So it's a matter of the unit. Medicare is not an issue because 30 mL is probably going to get a patient all the way through, But for anybody like Blue Cross Blue Shield, Aetna, Primera, then you have to figure out how you're going to do it. Okay? or Medicaid, because Medicaid may not go by ml. And unless the RCW's changed since I last read it, Medicaid said that you could bill for the doses as soon as the first injection was given. And the problem that Medicaid had in the state of Washington was that the patients would have the doses manufactured, then the patients would never show up. The physician would get paid for the doses, and they just expired in the refrigerator. Okay, so they came back and said, no, you have to give at least one dose out of that before we're going to pay you for any of those. Okay.
This has to be a branch of the IRS that's doing this.
Okay. So the 95165, we all know, we've talked about that. The 95144, I put that one up. I actually have one practice in the country that does all single dose vials. And
Every antigen is in a vial?
no,
What is that?
they may have multiple antigens in one dose, but every vial is one dose.
Pharmacy law 797 gets enforced. That's what we're going to be doing too.
So you mean they're putting alder, birch, and grass all in and then they've got 45 vials for the year. So every time they come in, they pull the next vial out.
Yeah.
Oh, okay.
That's a choice.
You make more money
There's gotta
that
be
way?
No, they don't
Waste.
make more money to get
Well, the
reimbursed the
pharmacy
same as
law, if the
95165.
academy doesn't win this
It's a
battle,
choice.
this is what we're going to be doing too. So,
There may be if they come.
because the law
The
now
20
is if it's
28
not,
day
if you don't get rid of it in 30 days, you have to dispose of it. So the academy's been fighting the FDA about this now for the last couple of years.
Right.
Because we're the only one grandfathered in at this point that can use a bottle after a month.
I think, and you're talking about the USP,
The USP,
797.
that FDA's a
797.
The last thing I saw in the USP 797 was there wasn't going to be a definitive
For a year and a half.
for a year and a half,
Yeah.
like 2019.
And that just came out last week. So
Yeah.
so it's been kicked down the road. And
Yeah.
for what it's worth, it's not just the academy. There's actually the otolaryngology and the college.
yeah.
And they are all
They all-
coordinating
Right.
very carefully on this. And we're very optimistic. But you don't know until you know.
It's the government.
Yeah. Yeah, but I mean, but they're listening and they understand our concepts, and they didn't 6 or 7 months ago.
Okay.
The venoms, the only thing I want to tell you on the venoms is that, remember, this is 1 staining, 2 staining, 3 staining is mixed vespads. 95147 is mixed vespads. 95148 is mixed vespads, honeybee, or wasp. And 95149 is mixed vespads, honeybee, and wasp. That 95149 includes all 5 bees, so even though it's 3 injections, it's 1 dose. Okay?
Whole body, is that fire in it?
Whole body is fire in. We don't, in Washington, do a lot of fire ins unless you have a patient that comes from the south that's doing it as it goes along. The thing on the rapid desensitization, in addition to what we previously talked about, is one of the things I want to remind you is that when you're doing drug desensitization or drug challenging, you have to code for the patient's reaction first. So let's say they had an injection of an antibiotic, cephalosporin, and they had a reaction. You code the reaction first, whether it's urticaria, whether it's angioedema, whether it is an anaphylactic reaction to an appropriately medication, and then code the drug. Because if you just code the drug first, you won't get paid. Because the drug code is a secondary code. So first code the reaction, and then code the drug. Okay? That's the way it works. You can also use the Z codes for the status of, for the patient that comes in that 10 years ago or 40 years ago, they were given penicillin, they had a reaction, and now they need it, and you need to test them. But don't use the unlisted code. Use the code specific to the drug, whether it's penicillin, cephalosporin, whatever it is. Use that specific code. Those are Z codes. Don't use the Z code and the T code for the drug together. Use one or the other as it goes along. Charge by time for rapid desensitization. The doses for the desensitization may also be covered, and that the food and the regular antigens are not covered in 2016. Those are things I think you need to know about. I want to jump over here to, because I'm running short on time, I want to talk about these a little bit. Some of these, the allergy, the slit. If you're doing slit, the only thing that's approved is grass and ragweed. If you do anything else, it should be cash.
Isn't there a dust mite product on the market?
Yeah, it's coming. It's being launched in the next couple of weeks, I think, right?
It's being launched in January 2018.
Then the both mites, or just?
I have not been trained on everything that's in it, but it's the dust mite tablet, and I'd imagine it'd be both DP and DF.
Yeah, it's got FDA approved, so presumably
Then
it'll
it
get
will
paid
go
for.
in this, but the problem that the question you guys come back to me on, grass and ragweed now, is you want to bill for that, as far as you want to bill a challenge, or you want to bill an E&M or something. It's just like giving an allergy shot. If the patient comes in and gets the tablet, and you ask them to wait 20 minutes, you might be able to get a nurse visit or a physician visit if you see them and pay attention to them for whatever their issue is. But you can't bill for a challenge. You can't bill for desensitization. That's just the tablet. So it's comparable to doing, so the house dust mite would be the same thing. Okay? So it goes along. The Xolair and the Nuclala. Payers are not wanting, and I don't know why, but they are not wanting to pay you the chemotherapy, the 96401, for Xolair. Now, either one is correct. My theory has always been if you want to step up and use the chemotherapy code, the 96401, which is for monoclonal antibodies, then you need to document the work component that's involved in it, whether it's part of your policies and procedures manual that says this is how we do it, this is the work that's involved, this is what it takes to get ready to give a Xolair shot versus compared to giving a Kenalog shot. Okay? What's the difference?
There's a black box warning on it.
There's a black box
For
warning.
God's sake, they're making us do this work, so we should get paid for it.
You should, but someplace along the line, medical directors have said, nah, it's not worth it. These people are doing it, it's not a big deal, blah, 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 so we don't want to give them the 96401. There's a significant financial difference between the two codes. So justify, if you can get your 96401 and you can have an impact on that, make sure that you get paid for that as it goes through, okay? The 96372, Meridian, a long time ago, said that they weren't going to pay us the 96401. So just watch that as it goes along. Okay, that's a big deal. Either one is correct for coding purposes.
How about the IV ones that are getting approved now? So
For IVIG?
no, well, IV monoclonal. Yeah, Reslizumab, for example. Is that I mean, that has to be well, I guess it depends where you're administering it.
Yeah, you can do it in your office.
And then do the chemotherapy code for that.
Well, if you're going to do IV, you're going to use an IV code.
So it's separate.
It's separate, yeah.
We're running out of time, but do you want to comment about oral food desensitization that's going on in this community, or?
Oral food desensitization that's going on in the community. If you're doing multiple doses, you can do rapid. If you're doing one dose, then there's no really way to get paid for oral desensitization for foods. The other thing is that you better make sure that the payer is going to cover you for getting paid for oral food desensitization. I know there's some companies out there that are making tablets for giving like peanut in a tablet, that type of thing, that you're going to get one tablet today, another one tomorrow, et cetera, et cetera. Those are all things that are on the horizon. Whether they're going to get paid for by the insurance companies or not, it's nothing. I don't know at this point in time. How are you coding for oral desensitization?
We're not doing it.
Right, because you don't get, but there's going to be presumably potentially a product in the next year to year and a half that's available, and there's probably 5 to 10 million patients out there that whose parents are going to want them on it. So there's going to be a big operation for somebody.
I think that's going to have to be motivated by the beneficiaries to get their payers to cover it. Obviously, it would be less expensive than a few trips to the ER for somebody that goes into anaphylactic. But I think that's going to be the way it's going to work.
Is it worth trying to document all this up front so that they don't come back and say it's not appropriate, or is it just the luck of the draw with the insurance company?
In regard to oral desensitization?
Or any of these things where we have to have the patient stay an extra length of time, like their first Xolair shot, they have to wait 2 hours. So again, it's not just a shot at that point. It's actually a 2-hour observational event.
But how much are you or your staff observing them?
Well, we're like other things, we have to be immediately present. On the question of whether we sit there and look at them, I don't think that's ever been the issue. It's just you have to be immediately available during these events. Right. So we are immediately available. We're not going to sit in the room and chat with them for 2 hours.
You usually see them in the beginning, the middle, and the end.
Right. And
often it depends how many doses.
Right.
If it's an egg challenge, you might, because there's an emotional component to it so seeing the doctor for 5 seconds every half an hour is often a helpful thing.
Part of this goes back to practice parameters as far as what you're supposed to do, what's included in that. The challenge, you're supposed to be there, you're supposed to check on the patient, etc. The Xolair, as far as, you bill an E&M for that, probably first encounter to give them all the instructions and those type of things. But without your face-to-face or, as an option, your staff's face-to-face, there's no way for us to capture that time. Okay?
So even though it's required that time is there, you can't justify that to a payer.
Right. Now, if it's interrupted time that, you have, let's say, a 90213 for the patient for the first visit, okay? They're healthy, asthmatic, you're going to put them on the Xolair, okay? And then, in addition to that, 90213, you spend another 30 minutes interruptively during that 2 hours, then we can add a prolonged services to it. That's a way to capture your face-to-face time. But I don't have any way to capture any time for the patient that's taking up space in your office.
A space-occupying tax, you can't put that on.
Well,
the bottom line is everybody needs you standing with them with every patient encounter every day saying this is how to code it.
Well, you pay my parking fees, I'll come. Thank you, guys.
Thank you so much.
This is more complex than primary immunodeficiency.
Or monoclonal antibodies landscape. This is more complicated than all that stuff.
Well, I don't have any dinner time, but college time, but I.
It's ridiculous. This has to be the IRS in charge.
I don't know how you keep this all.
That's why I can't go ahead.
You're not the not once in a while. Oh, you.
Thank you for trying to straighten that out.
Great call. You think as a doctor taking care of patients is what's medically correct. For me, it's impossible to keep this thinking in my head at the same time.
Yeah, you got it. There aren't really so every chart gets evaluated by coder before it gets submitted. They go through all of our documentation, everything we did, and they decide what code it is, and they have to change it.
Do they let you know if they change it?
If you want them to, otherwise no.
Yeah. I disagree with that. The reason I disagree with that is how can I make your chart better?
If you keep screwing up, they'll send it to you. Individual chart is not.
It's not a single
subscribers.
If you got it, something every year.
More money.
And we don't want
There's still an issue.
patients who are having Thompson.
I understand what you're saying, but we have so little advantage over this. This is an afterthought after everything else, like Wayne said. This isn't how we're trained.
I know, they are working on it. It is breaking down.
Sure.
I don't get to see you, do they? Are you normally in,
Well, I'm,
Yeah.
thank you very much. Good to see you.
They just tell us if we're putting in
Yes,
sort of
get some
not the
copies.
safety indication?
It's a tough topic.
Absolutely. Does every chart go
I
to
travel
the
in planes and trains travel.
Yeah,
I know how that goes.
Well,
Thanks a
good
lot.
luck.
Nice to
Thank you
meet
with
you.
your help on the research.
Oh, sure.
5 years. But then, you know, just having
Your hotel.
What I like to ask about is what happened when we get the printout
you know, kids all these things. You can see the
from, let's do a sign that.
Saves a lot of money getting
And then you can put the interpretation
Yeah.
after evaluation.
So I've never done that.
Yeah, I've heard that. I know, so it's
How are you
Rarely
Oh,
we
good.
see Steve over
I
here.
brought him with.
You can see I'm sort of depressed.
Hey, good for showing up.
It's like,
Are you
Yeah.
in Redmond today?
No,
I'm in Redmond.
I know that.